Good afternoon, and thank you for joining us for today's session on putting social determinants of health data to work. My name is Rich Morino. I lead a team of solution consultants here at LexisNexis Risk Solutions Healthcare Division. And I'm happy to be presenting today, bringing some of my over 25 years of experience in data analytics, and predictive modeling. Later in the presentation, I'm joined by Karin VanZant, who is the VP of Integrated Community Partnerships at CareSource. So let's go ahead and get started. On our next slide, we'll explain our topic. Today's topic is putting social determinants of health to work, and we divide it into the conversation into three agenda points. I will discuss identifying who is at risk and why, along with operationalizing the data. Karin will then take us through CareSource calculating the impact. Afterwards, we welcome your questions. So let's go ahead and get started. Before we dig in to identify who is at risk and why they're at risk, let's recap why so many organizations are looking to social determinants of health to inform their member engagement strategies. If you read research from organizations like Kaiser Family Foundation, you'll see the quality of care only accounts for 20% of a member's overall health outcomes. That's sobering, given how much work we all provide, only to know that it's likely the factors outside of the engagement which will determine the health of the patient. Further, genetics only accounts for another 20%. These are members that drink a pot of coffee a day along with a pound of bacon and live past 100. Or conversely, it could be Jim Fixx, who literally wrote the book, The Art of Running, but died at 52 due to genetic family history of heart issues. That leaves 60% of outcomes decided by conditions outside of genetics and healthcare, which the quadrants on this slide illustrate. But let's move to the next slide to dig in a little deeper. So now that we're armed with the facts of the importance of managing non-clinical aspects of patient outcomes, let's discuss the type of insights that can be gained through social determinants of health. When we talk about social determinants of health, there are really three major initiatives that our industry is pursuing. The first is the use of social determinants of health on chronic disease populations to predict who are likely to be deteriorating and what socioeconomic barriers to health there are that need to be addressed. The second popular use case is to segment your entire population into risk groups, and then use social determinants of health to determine which populations that are healthy now are likely to become sick soon due to their socioeconomic status. So trying to identify people who are likely to move down the continuum before that actually occurs. Then finally, the third one is to assess the entire member population to understand which conditions are most populous and where they are. So a strategy could be built on how to align and build out social services. Now, in each instance, we're hunting for health barriers, such as social isolation. This text on this slide indicates it can be significantly increase the risk of heart disease and stroke. In fact, today we know that social isolation, or even the feeling of loneliness, can be worse for your health than smoking. This slide also addresses health literacy, stress, and the impact of living in poor neighborhoods on your health. None of this information is really radical or new to us. It's just rarely collected in any member interaction. So how should we design a process that collects this insight and makes proper use of it to improve health outcomes? Let's go to the next slide and take a peek at that. So there are three important pillars to the social determinants of health project for any of the use cases we just discussed. First, identification of which members are at risk and why they're at risk. Now, the why is the critical part here. Simply a score of a risk member is almost worthless to a care coordinator to determine what, if anything, can be done to a member. We heard in the early iterations of social determinants of health, okay, this individual has a score of 94. That means it's risky, but what do I do with that? So that leads to another component. Many health plans struggle here, usually lack for good insight. They're trying to gain insight into who of these members are at risk. And the tools that they have at their availability aren't that sufficient. You have ICD-10 Z codes, which have barely any adoption to date. There's hope for the future on that. Then you have HRA surveys, which are not close to wide adoption today. If you look at some of the research out there, they say within a commercial insurance population, only 4% annually fills out a health risk assessment, leaving lots of holes in understanding which members should be prioritized. So this really requires health plans to collect and append objective third-party data to create longitudinal records, which can inform them what they need to do. Now, getting the results and the second pillar into the workflow of care coordinators is critical, and we touched on this already. If you get a score, and you get information indicating why that person is at risk, it is exceedingly difficult for care coordinators to make use of this if it isn't in their existing case management system. So getting the information that explains who's at risk, why that risk, and in a timely fashion to the care coordinator at the time of patient engagement is extremely important. And then finally, there's the taking action. What do you do with this insight? You need to align a community or social service to the at-risk member. And this so insight needs to turn into action. And critical to improving health outcomes is identifying a local resource to your member that can address specific socioeconomic barriers. Let's dig into this in a little more detail on the next slide. So when we talk about that first pillar, identifying who is at risk and why, our market seems to be coalescing behind two types of solutions. Now, the first is socioeconomic, I'll call them attributes, but data insights. This is that objective third-party data that spans all 5 categories of social determinants of health. Now, if you look out at all sorts of research institutions, almost everyone says that there's 5 broad social determinants of health categories with several subcategories underneath them. I will say Kaiser Family Foundation actually breaks out food, access to food and food desert from its neighborhood and built environment and considers its own characteristic or its own category. But by and large, everyone's looking at 5. Those are economic stability, social and community context, access to healthcare, neighborhood and built environment, and education. So you need to have information that spans all those categories. Simply one is not enough. And I'll give you an example. There's a neighborhood in Chicago where I'm from that is just north of Wrigleyville. It's called Uptown, for those of you who are familiar with the Chicago area. Now, it's just near Wrigleyville, which is a very wealthy area, and it's right on Lake Michigan. Also seems to be very desirous. But in the 1960s, more Section 8 housing was set up in that neighborhood in Chicago than any other in the entire city. So if you were to take just neighborhood information and try and ascertain someone in that community's socioeconomic health status, you would automatically think that there might be a chance that they're transient or live in Section 8 housing. They live in a food desert, and you know they'll likely have a low economic intake or perhaps financial instability. But that's just trying to ascertain that member based on where they live. Reality could be that they live 3 doors down from Section 8 housing. They drive an expensive luxury SUV, and they could drive to Whole Foods and buy overpriced produce, meaning that they do not have a diet of only pre-processed foods, which would correlate to diabetes. So getting to that member level insight is critical. And then finally, you need to make sure that when you're trying to get a rich resource of additional non-clinical information to append onto your member insights, you need to make sure that this data has been through, has been clinically validated. Let's put it that way. Oftentimes what we'll see is entrants into the market are saying they have social determinants of health, and that really what they mean is they have just data about your member. And is it actually useful? We see a movement within the industry to say, if you're truly to call yourself social determinants of health data, some statistical rigor should be going through this to make sure that the data elements being provided are statistically correlated to some type of health risk. And therefore, depending on the predictive model you're trying to build, it's going to have impact, as opposed to having analytics teams spend 80% of their time simply evaluating data to see whether or not it might work and only spending on data prep. So that's the value of when you're examining data sources, making sure that it has some statistical correlation to health risk rather than being a data dump. Now, these attributes and all the information I just shared with you are useful to our clients who want to go ahead and take this information in and append it to their clinical information and derive all sorts of insights from their own analytical teams. Then there's, on the right side of this slide, socioeconomic health scores. And this is for health plans that want the models essentially built for them. These are models that are built only on socioeconomic information. So you have to be picky about what your target is on this. For instance, things like ER utilization, readmissions, or motivation to attend a preventative screening are all good examples of targets that could be modeled from socioeconomic data alone. However, if you're thinking about things like knee replacement or lumbar issues, remember when we talked about Jim Fixx and the art of running, there are some things which are more genetic driven. And sure, you could do a decent job on a model by combining clinical and socioeconomic information, but you wouldn't want to use a socioeconomic model alone for such genetic driven conditions. So this is how we see right now the identification of who is at risk and why, how it's being done, either through the use of data which can be appended onto your own claims information in a warehouse, or scores which could be deployed only on socioeconomic information. Let's move forward and talk about how these are being deployed these days. So I think you're getting the sense of the theme of three. When we talk about how to identify who is at risk and why, there's really 3 steps. But broadly, what we're talking about is think globally and act locally. By thinking globally, we mean to segment your entire population and identify the frequency and density of specific health barriers. Then you map these to understand where you need to make long-term decisions on which health services to build out yourself, which ones to partner with existing services, say for instance Meals on Wheels for members in a food desert, and which ones will take longer to build out. For instance, sometimes strategies for people who are housing unstable take a longer tail end to go ahead and make sure up and running and make an impact on your members. This exercise can seem daunting and sometimes leads to paralysis by analysis. Instead of analyzing, the key to preventing the analysis paralysis is to make sure you simply assess your member population for the purpose of long-term planning, that isn't your short-term action. So the next step is to act locally. In this step, you want to reverse the analytic process. Instead of analyzing the entire membership to see which ones have health barriers that exist, instead you're modeling to see which members in a very specific geography have a very specific health barrier. For instance, let's pretend you have a significant membership in Illinois. You already have a relationship with Lyft for Medicaid members to supply them non-emergency transportation in the Rockford, Illinois area. So let's see which chronic members, A, live in the Rockford area, B, have a lack of transportation as one of their top health barriers, and then C, align them with Lyft for pickups for preventative screenings and lab tests. This is an excellent example of acting locally. And this has 2 benefits. It allows health plans to take action quickly through existing partnerships and social services, and can also impact your HEDIS or STAR scores. Now, to achieve this goal, simply model on chronic condition members who need transportation assistance. Reach out to them and see if they need help getting to their breast or colorectal cancer screenings or comprehensive medical review for medication therapy management. Now the member is more likely to be healthy and you benefit from a closed gap. Let's examine this in more detail. So when we focus on quality scores, what you see on the top are the 2 most widely used quality scores in health plans, which are HEDIS by NCQA and STARS on CMS on the top half of the slide. You can see that they have a lot in common. For instance, HEDIS has 3 types of measures: process measures or preventative screenings, patient experience, often referred to as CAHPS satisfaction surveys on providers in the health plan, and outcome measures, whether necessary treatments for specific conditions actually occurred, along performance on key initiatives like statin usage or readmissions. STAR has 5 domains of scores for health plans, with another 4 for prescription drug plans, which we won't get into today's session. 3 of those categories are almost the exact same as the HEDIS measures we just mentioned. So whether you're focused on quality ratings for managed Medicaid or employer-based lines of business, focused on HEDIS, or Medicare supplement or health insurance exchange lines, which focus more heavily on STAR, most of the measures are the same. The question is, how do you want to employ social determinants of health to improve these scores? Let's dig in a little deeper again. So on this next slide, we're going into more detail and we're examining for process measures. It's critical that we identify which members need to attend these preventative screenings and if there are any socioeconomic barriers which would likely prevent them from attending. Now, examples can include lacking transportation, low health literacy, so don't understand why they need to come in or that they should come in when they aren't sick. They might be socially isolated, or there might be economic fear, so they could be financially unstable and don't understand the screening is covered at no cost by their benefit. The most effective model we've seen is the motivation score for these process measures. The idea is to predict who is likely to come in on their own and why. For instance, someone who's had several certifications, say a lawyer, doctor, teacher, or plumber, is more likely to be engaged in their own care. So you can feel somewhat comfortable that they'll attend the screenings on their own. Patient experience can be impacted by the act of attempting to reach out and align services to your member. Any member who has received this communication typically tends to respond very positively to satisfaction surveys. And then outcome measures are weighed the heaviest. An excellent example of a model for outcome score is the 30-day readmission risk score. Now, if you look at the entire episode of care, the inpatient portion can be fairly well managed. However, when a member is discharged, where and how they live play a much bigger role in determining whether they return in the next 30 days than the quality of care they receive while they're in the hospital. In this next section, we're going to focus on operationalizing data, and we're going to give you an example of this. So let's start talking about operationalizing the data, and let's dig in right to our example. We're now looking at PCR, the business case, which is all plan cause readmission. So according to NCQA, all cause readmission assesses the rate of adult acute inpatient stays that were followed by an unplanned acute readmission for any diagnosis within 30 days of a discharge. Obviously, there's a lot more to it, and it gets into observed versus expected, but I'm here to talk about this in English. So let's go to the next slide and translate it into common speak. If we could go back one slide. Perfect. So when we're talking about planned all-cause readmission, it's a prediction made on the number of adult acute inpatient stays that were followed by an unplanned acute readmission for any diagnosis within 30 days after discharge. If you manage the member population to less observed readmissions than expected, you get full points and a score that would be indicative of less than 0 on this observed to expected ratio. If you manage to arrive around the expectation on number of readmissions, you're not negatively impacted, and you typically arrive at a score around 1 on the observed versus expected ratio. However, if you have more readmissions observed than that were expected, you're going to get a score of more than 1 on that ratio, which could lead to poor HEDIS scores, higher readmissions as well. So to the left, you can see some of the indicators that socioeconomic readmission model uses to identify who is most at risk. So you're using socioeconomic data as triggers, as leads, built into a model to identify who are these risky people. And some of the things that have been proven to predict this readmission in 30 days are people who've had a significant decrease in income over the previous year. They've moved addresses at least 3 times in the last 12 months. They've recently moved into a high crime neighborhood. They don't own a vehicle themselves. They live with someone over the age of 80, which means that not only they're dealing with their own health issues, they have to be primarily caregiver for someone else, as well as probably have financial stress of managing them as well. And then finally, that they're socially isolated, live alone with no close associations or relatives nearby. It's information like this that if you could glean through socioeconomic data and find members that are at risk for the categories I just mentioned, those are likely the people who are to pop up back into the hospital in the next 30 days. And it's critical when they're discharged that you have this insight on them. So let's move to the next slide and take you to a real world example of this. So right now we're looking at an example of 4 gentlemen with the same clinical diagnosis of heart disease. We have Tony, Alex, Chris, and Greg. Clinically, they look the same, but let's see if their story looks the same after examining socioeconomic data on the next slide. Despite the same health system, similar age and diagnosis, their predicted likelihood of readmissions are vastly different. This is critical to any clinical care coordinator to know. Now we know we could probably keep Chris through wellness investigations and occasional outreach to make sure he's following prescribed medical protocols. However, Greg is going to need a much more severe intervention plan. In order to come up with this plan for Greg, we need to know his why. What is driving this very risky score? Let's go to the next slide and take a peek. So the first socioeconomic care gap you see associated with Greg there is housing purchasing activity. This means Greg probably has frequent changes to his address and may indicate some inconsistent access to housing. The second socioeconomic care gap we see is transportation. This means Greg likely doesn't own any vehicles. Now, based on where he lives, this could be a significant problem in trying to maintain his health and keep him from being readmitted. Finally, we see education. This is information that relates to his level of education. which may indicate insights into health literacy challenges. Knowing these three pieces of information on why Greg is at risk, now a clinical care coordinator can engage to suggest some services such as temporary housing, non-emergency transportation services, and send health information or videos at the appropriate health literacy level. It's the why that helps us build out an appropriate action plan. So now that we've gone through who's at risk and why, as well as operationalizing the data, I'm going to turn it over to Karin to discuss the calculating the impact.
Good afternoon, everyone. This is Karin VanZant from CareSource. A little bit about myself. I am a social worker and community developer, and I've been with CareSource for about 5 years now, overseeing our build out or life services department, which equates to our social determinants of health or SDOH department. You can go to the next slide. A little bit about CareSource. We are currently in 5 different markets or 5 different states, have just under 2 million members, and have a variety of health products. So from Medicaid to the marketplace to Medicare Advantage and duals. Most recently launched a D-SNP in our Ohio model. We are based in Dayton, Ohio, and have been headquartered there for approximately 30 years, mostly focused on the Medicaid population. And so as we talk about social determinants of health, as Richard said, these are kind of the non-clinical things that are happening in a person's life that may have a positive or a negative impact on their overall health outcomes. And so our life services department, go to the next slide, actually consists of 5 pillars. Given that we are a health managed care organization and oriented already towards health and health access, our 5 pillars really focus in on housing, workforce development, food and nutrition, special populations, and advocacy. And so to talk a little bit about each one of those pillars and the types of SDOH data that we're extracting and the utilization of that data, like to say to those folks that are in the healthcare sector, if you don't know where you're going to lay your head each night, it's really hard to focus on health outcomes. And likewise, from a housing perspective, you could be the most compliant parent of a child with respiratory problems, but if you live in a 100-year-old house that has lead paint and asbestos and may also have mold, it's really hard to see positive health outcomes no matter how compliant you are on the clinical side of treating that child's respiratory issues. And so those are the kinds of things that we're working on at CareSource to really put into and integrate into our overall care model in the same way as we have pharmacy care and behavioral health care and clinical care. We believe social care is a very critical factor to our overall health outcomes for our members. And given that we're a plan that only serves in the government healthcare realm, we understand that a lot of our members may be in those vulnerable populations or lower socioeconomic statuses that would lend itself to having poor quality housing, lack of food and nutrition, lower levels of education or employment. And so those are the ways in which we've configured our life services department. You want to go to the next slide. We'll talk a little bit about the variety of sources of socioeconomic data or social determinants of health data that we have coming into the company. Some have historically been there, and some are new as we've continued to build out life services and recognize the gaps in information that we have from the healthcare orientation or clinical orientation. And so one of the things that, that all plans have is some kind of a health risk assessment. We're receiving data from our state partners, our federal partners on, the state Medicaid 834. And what we are seeing is there are trends in the last couple of years of receiving more socioeconomic data from those consistent pipelines that have been built around managed care. But there are big gaps in the amount of SDOH data sources that we have as a plan, both that we cultivate on our own with conversations with our members, as well as what we receive from our state partners. And so, of course, we are working with our providers and the HIE data that we get. If providers are using some of the things that Richard talked about, the ICD-10Z codes, or the use of assessment tools like Prepare. We have some online tools, but we've really had to look at in the last couple of years the way in which we partner with vendors to consume data sets that exist in other sectors or segments of the population or other parts of the systems that our population may be interacting with. One of the things to know from a Medicaid perspective, on average, our Medicaid members, from a CareSource perspective, and many other plans, I would assume, are interacting with other safety net benefits, sometimes upwards to 10 to 12 different other safety net programs that all have their own data sets that most times sit at the state or at the federal level. And that don't integrate in any way or communicate back and forth. And so when we looked at that last bucket from a life services perspective, advocacy is always a primary bucket for us, is to advocate for those data sets to start to come together in a more cohesive way as we're serving some of those same populations from program to program at a state or at a federal level. So a couple of examples that we have from the SDOH data that we've done in the last 5 years. We've got, and those of you that have heard me speak about the life services or the Job Connect programs, we've got a lot of data that we collect from members that are working with our life coaches from educational background and employment background, and that they self-report back to us. But really looking at the scale of some of our SDOH pilots and programs and the fact that we serve nearly 2 million members, we really needed to be able to consume those data sets at scale for all members across all of our product lines. And then be able to, as Richard said, it's not just the who from our membership that may have gaps in care from an SDOH perspective, but then how do we work that into our workflows from a case management perspective? How do we act then on that data in the same ways that we act on clinical data? If we get a diagnosis code in from a provider that somebody is pre-diabetic, we already have established case management plans that would indicate or trigger a response from us to do outreach around wellness and disease management programs and protocols around the case management there. There's not such a well thought out and rigorous response when it comes to a member identifying that they're at risk for homelessness, or that they're food insecure, or that they report that they're in a violent relationship at home and may be experiencing domestic violence. And so as we've continued to build out our responses and to fully integrate into our case management systems, we're working with our leadership and with our community partners to have those same kind of regimented action plans in place so that it doesn't become one department's responsibility for addressing SDOH. It becomes a part of the care coordination philosophy at CareSource, that every member facing a person has access to the right kinds of tools and the right kind of action plans to help a person to be able to either get to a specialist on our team or to be able to access community-based partners in care. Our most recent example, and the one that I'd like to share with you today, has been around how we're working with our SDOH data and the CareSource response to COVID-19. And so as we move to the next slide, and many of us are living this right now and experiencing the really short pivot as lots of companies ended up moving their staff into work from home situations, worked with our health partners to assess the go, no-go types of things around healthcare access as we've all been working to address the COVID-19 crisis. And so we worked with our analytics team across multiple parts of our organization and our business continuity structure to bring in the right kinds of data source from an operations, utilization, management, our risk stratification from our care management tools, and geographic insights as it pertained to COVID-19. And a big part of this was the integration of our SDOH data that we've been collecting both from our member populations and health providers, but also that vendor data, and actually getting it into the workflows of business development or business continuity, and being able to act on it on a regular, sometimes daily as we were having those meetings, or weekly basis. And so again, that collaboration with our analytics teams to compile the variety of data sets that were out there into a dashboard, and then looking at the deployment of this dashboard so that all of the leadership across the organization, particularly now that we were decentralizing and moving much more into work from home situation, would have self-service access to the dashboard was really important. And then how we continue to update that in an automatic way, update that dashboard with data sets that were coming in and stratifying members with a new lens. And that lens was of those that were symptomatic for COVID and were testing positive for COVID, and how we then started to do some of our own internal hotspotting based on our membership. You can go to the next slide. So as we looked at this dashboard, and of course now we're into the end of the third month, almost the fourth month into the COVID crisis, this dashboard has become really important to all of our leadership as we look back at the weekly utilization trends specific to COVID. As we've started looking at the projected costs, this additional risk stratification within our membership, and our geo-mapped hotspots and insights, as the largest managed care plan in Medicaid in Ohio, through much of this, there were daily and weekly calls with the Department of Medicaid as we were all trying to lend data and support in the COVID crisis. This was one of those ways that we weren't just relying on our clinical data, but we also, as we increased our member engagement and outreach, we're able to get some of that self-reported data into the hands of leadership to keep our thumb on the pulse of where folks were at. And then, from a business leader's perspective, it was about, really keeping all of us abreast of the daily breaking news. The way in which my team, from an SDOH perspective, utilized this dashboard over the last couple of months, and as it ties back to the life services, was really twofold. The first is, given that we've run a workforce development and a jobs program for 5 years, kind of our signature program out of life services that started in 2015 was Job Connect. And we've all seen the headlines over the last 3 months about the 20 million plus individuals that have filed for unemployment as businesses closed. It was really important for us to increase our outreach to our members, both those that were in the pipeline working towards employment, as well as those that had already become employed, that we were continuing with coaching and support past the point of employment, so that we understood what was happening with their specific family situation and within the employers that they were employed at. We also reached out to our almost 500 employer partners across our 3 markets to survey them to see which ones were having to shut down, who was pivoting. We saw a lot of our employers really pivot and start to repurpose what their current products and services were to be able to help in the midst of the COVID crisis. And then those that were actually ramping up and hiring more because they were deemed in their state as essential employers, and were really taking on a bigger workload than they had anticipated. That brought information back into our business continuity team that I think really helped us to better understand not only what was happening from a CareSource perspective, but what was really happening in the regions and in the states that we serve from a member and a provider standpoint. So then we were able to make some business decisions. One of the business decisions was around the personal protective equipment that we had as we decided to stop doing face-to-face visits with our care managers, and we could work with our health partners and our employer partners that were deemed as necessary and critical. We were able to deploy PPE that we had on hand, as well as leverage some of our vendors in that space to be able to connect with our partners in our regions. The other area that we were able to use to do a response with was in the area of nutrition and food access. We have a director who's been working on nutrition and food access for a couple of years. We have a fairly robust partnership with our food banks and our food bank associations. And the very quick pivot to the ways in which many of our food programs are distributed across the country, which are mostly in congregate settings such as schools, senior centers, things like that, pantry systems, and pantries that have really configured themselves much more like grocery stores versus pick up a box of food. All of that would really kind of put the brakes on at the end of February and the beginning of March. And so working with our community partners and being able to bring that information into our clinical conversations and our business continuity to talk about, we knew that the first population that was going to, as we looked at what other countries were doing and across the month of February, is that seniors were at a greater risk. And we know that many of our seniors on our duals plan and our DSNP plan rely on senior congregate meals, the services of our AAAs and Elderly Uniteds and senior centers, and that those were probably not going to be able to operate, as well as seniors were being told to stay home, especially those that may have complex conditions. And so how do we insert ourselves from a plan perspective, and how do we encourage and get the right level of care out to those members as it pertains to food access and nutrition? And so it was, we did a lot of work over the last 3 months, but both from funding and working with our foundation to get funding into the hands of those food distribution infrastructure and sectors to pivot and be able to change the way in which they were delivering food to our members. We increased our outreach and connection points, but we also transitioned our non-emergency medical transportation benefit. One of the things that we were talking with that vendor on is, how low our transportation utilization was, as we weren't, our health partners weren't doing face-to-face appointments, and all kind of the healthcare sector went to focus on really the essentials of addressing COVID-19, and other ancillary services were not available for a couple of months period of time. So we made the decision to utilize our non-emergency medical transportation to help out with the void of transportation for members to be able to get to the school lunch distributions. Many of our members rely on public school buses to get their kids back and forth to school, and those transportation services were shut down. We've been working with USDA on the SNAP benefits and online, and that requires some transportation at this time. So it was really interesting to be able to bring our viewpoint from a company perspective, the data that we were consuming from both our providers as well as our vendors from an SDOH perspective, into a structure like business continuity, and allowing for that to have an equal place at the table to really show what was happening with our members through this COVID crisis. We've got several other examples, but I know that time is running short. And so maybe we can address some of those other things during the questions and answers, but really appreciate Lexus asking for CareSource to be a part of this presentation. We've partnered with Lexus for 4 years. They are one of our vendors in the SDOH space. And we've learned a lot from working with their teams. And I think likewise, they've learned a lot from how we're really trying to be in that, how do we get this into the workflows, and then how do we act on it space, since there isn't a lot of standardization in SDOH from a plan perspective. And we're still all kind of in that new development or that innovation space to really kind of set what those standards are going to be moving forward. So I look forward to the continued discussions and the questions and answers in the next part of this session.